dear friends, colleagues from across the world now, I would say, who've logged on and who've registered for this exciting symposium, the second of the APSIC webcast 2020 from the Asia Pacific Society of Cardiology, dealing with the practice pearls in interventional cardiology. And as you would note, that we are covering 9 hours of a time zone. From Saudi Arabia, we've got listeners and audience from Mauritius, all the way up to New Zealand. So it's really exciting to have some of the greatest experts of interventional cardiology here with us, who are going to give some practical pearls in tough calls of PCI in heavily calcified lesions. We well realize that heavily calcified lesions is, of course, a nemesis for us. We don't like it at all. Whenever we see an artery which is heavily calcified, we say, oh no, not me, why am I doing this? And we well realize that nearly 30% of the cases which we do have some moderate to severe calcification. 10% of those are fairly severe calcification. As we do more and more elderlies, those with previous bypass surgeries, those with chronic renal disease, elderlies, diabetics, all have heavily calcified vessels, and truly it's very difficult to deal with heavily calcified vessels. They are prone to perforations, the inability to deliver stent, inability to expand stents, need adjunctive devices to get the best results, and certainly lead to one of the commonest causes of stent under expansion, subsequent worse outcomes with stent thrombosis and restenosis. So really, the worst form of lesions that we've dealt with. But luckily, we also have advancements in dealing with them. New devices have come in, and therefore it just is apt for this forum today to actually go through the new tools for treating heavily calcified lesions, and then hear the experts present some of their toughest and most difficult or most educational cases, highlighting the management with the use of many of these devices. And actually, whether it's the speaker or whether it's the panelists today or the moderators, we're all one together. Everybody's able to comment, everybody's an expert. It's not just that the speakers are there as experts, actually our panelists are also as much experts at those new technologies as they are. And it'll be an exciting discussion, the way I see it going forwards. It's going to be an exciting discussion, perspective, as well as question and answers on and tips and tricks coming from everyone I would see who's a part of the meeting today. So with those words, I think I would hand it over to Dr. Damras, and Dr. Damras and myself would moderate the first session on new tools for treating heavily calcified lesions. We have as panelists Dr. Ravinay Bhindi from Australia, Dr. Zhang, who's well known from China, Ramesh Singh from Malaysia, and Khalid Faraidy, my dear friend from Saudi Arabia. And with that, I would also just, before I hand it over to Damras, I just introduce to you Dr. Cassese as well, because Salvatore Cassese is from Munich in Germany. He is a graduate of Naples School of Medicine and has been a postgraduate also from the Naples Schools. He is head of department at the Munich Heart Center. He's published a lot. He did his PhD also in Naples, and then of course he's an expert in new tools for dealing with calcified lesions, especially the talk he's going to give on the role of ultra high pressure balloons. So over to Dr. Damras, over to you to take the sessions forward.
Yeah, thank you, Ashok. We have 2 outstanding speakers for this session. So the first one is necessarily where he talked on the high pressure balloon inflation for calcified lesion. Please, you can go on. You have 12 minutes for presentation and 8 minutes for question and answer.
So I hope you can hear me, everyone.
Yes, we can hear you.
I'm very honored for the presentation from Dr. Seth, Professor Seth, and from the kind words from every one of you. Thanks for inviting me. Thanks for having the opportunity to share the experience of my center, not my experience, of my center with these kinds of lesions, as the professor said already told us. And I will start for the audience with something that is going to remain in our heads more than a lot of words. This is a common osteum of a lady that presented at our institution with a tight and very calcified, this horrible stenosis the professor Seth referred to, and the lesion was placed on the distal left main, if we can call this left main, and it was extended in the LAD and on the left circumflex. As you can see, there was an extensive rotablation. This was the 7th run of a rotablation in this vessel, and as you can see also with the guiding extension device with the CTO guide wires, it was possible to cross also the LCX in that way, and then we achieved it after the post-dilation with the super high pressure balloon, ultra high pressure balloon. We achieved a satisfactory result with the implantation of 3 stents. This is a paradigmatic case because, you know, there are a lot of people which present in our daily practice with this proportion of calcified lesions, and you can see that the more severe the calcium, the worse is the outcomes. It's not a matter of we don't like to make these lesions. These lesions are important also for the as a prognostic parameter to evaluate how good our patient will do. And this is a pooled analysis for 2 randomized trials, horizon, semi, and acuity. And you can see that the presence of moderate to severe calcification in the coronary artery tree was associated with a higher risk of all the components of a worse outcomes: all-cause mortality, cardiac mortality, myocardial infarction, target vascularization, and MACE. And this was published last week, or last 2 weeks, on JACC intervention. This is a pooled analysis of 80 randomized trials of drug-eluting stent, and it was possible to demonstrate that the more is the calcium, the worse is the outcome, and the contribution of new generation device of improving the outcome is not that much high that we expect. So for this reason, it's important to have the best technology to manage this kind of patient. Why is it important to have the best technology? Because if we could prepare adequately the lesion, if we could expand adequately our vessel, it is important, it is much more important if you have to deal with calcified lesions, because calcified lesions are the enemies of stent delivery and expansion, and they could damage this polymer and coating during the delivery. And for sure, all these things together led to an inadequate diffusion of drug to extensive calcium arcs, and these have a directly impact the effectiveness of drug-eluting stents by increasing the risk of stent thrombosis and restenosis. So this kind of lesion, the professor said, told about calcified lesions, but the calcium is one part of this problem, because the calcium is a part of the resistant lesions we face in the daily practice, and also the lesion with descending expansion belong to this kind of lesion, those with multi-metal layered in-stent restenosis or death thrombotic lesions and non-dilatable lesion after rotablation. So how we have to deal with this is the normal we have to face, with which we have to face this kind of lesions. For sure, standard balloon angioplasty are not adequate because they increase the diameter with the greater pressure. They have a nominal diameter typically at 6 to 10 atmosphere, and you know they are associated more than other devices with the dog boning effect. It means that the stent expand, the balloon expand on the distal part and proximal part, but where the lesion is, the balloon does not expand. Non-compliant balloons are a little bit better, but unfortunately, they are for sure more resistant to biopsy than semi-compliant balloon, but they are not every time the solution. Just another case, a patient who presented at our institution with extensive calcified proximal LAD, a tight stenosis also of the mid part of the LAD, and the aneurysm in the place where the stenosis is. We decided to rotablate it and take a look. A lot of people say that after the rotablation, the balloon, the non-compliant balloon, could for sure expand. But take a look what's happened. The balloon ruptured. And as you can see, at 24 atmosphere, everything that is inside the balloon go outside. It means that it can embolize air, contrast medium, and nitro. So in the next slide, you can see that the patient was hemodynamically unstable with some AV block, and the LID occluded abruptly. So what we did, we went with the guide wire in the LID, and we started a non-compliant balloon dilation at 24 atmosphere in the LID, but I will perform a magnification, dog boning effect. So we have two problems. The balloon in the non-compliant balloon in the proximal part of LID ruptured. The balloon in the mid part of the LID has a dog boning effect. So we need something else. And the something else could be, in my opinion, the ultra or super high pressure balloon. Twin layered technology, it means that there is a balloon within a balloon, and you can expand the vessel more precisely, more adequately, because there is a stable growth of, or minimal growth of the balloon between 10 and 35 atmosphere. There is a minimal growth of the balloon. It means that you cannot damage the vessel that much. And as you can see, we performed the pre-dilation of the LID with a 2.0, a 3.0 ultra pressure balloon at 40 atmosphere, and then we expand the vessel. We complete the preparation of the proximal part of the LID with the 3.5 OPN balloon at 35 atmosphere, and then we achieve the goal to perfectly expand the stent and to implant it. So, which are the use of this kind of balloon? For sure, the calcified lesion, but also the problem associated with stent implantation in calcified lesion. Take a look of this stent under expansion that was associated with the stent thrombosis. The patient presented at another institution. They sent the patient to a bypass operation. The patient refused the bypass operation, was transferred to our institution. We fixed at the first the LID, and then we crossed the almost occluded stent with the non-compliant balloon. Again, take a look, non-compliant balloon at the maximal atmosphere, again, dog boning effect, no expansion of the stent. For this reason, OPN, it means ultra pressure balloon at 45 atmosphere, expansion of the stent and the vessel. Stent implantation, very good results. So, for sure, another possibility for the ultra high pressure balloon is to expand the vessel once the vessel has a occluded or has a restenosis. Take a look at this patient presented at our institution, a gentleman, very young, already multi-metal layered in-stent restenosis. The last one was occlusive in-stent restenosis. It was treated with recanalization, OPN, it means ultra high pressure balloon at maximal atmosphere, and then 3 drug-eluting balloons were used in order to avoid further metal in this vessel, and there was a satisfactory result. And for sure, the stent under expansion due to calcification of fibrocalcific lesion is a matter of a big importance in the daily practice, because the more we implant the stent, the more we face the problem of the stent restenosis, and stent under expansion is one part of this problem. And we are starting with the multi-center registry in which we face patient with patient with destined stent restenosis. We prepare a standard preparation with non-compliant balloon, whatever you want, and then we will perform OCT. In case of a stent expansion below 0.8, that is recognized, well known as the objective of every good stent expansion, we will prepare again the vessel with OPN before using a drug-eluting balloon. Then we will perform OCT, and then we will see if the satisfactory stent expansion has been achieved, and which is the importance of this angiographic or imaging endpoint on clinical outcomes. A lot of people ask me, can we use OPN or ultra pressure balloon after rotablation? Yes, you can do. A lady that was transferred to our institution because in another clinic was attempted to make this kind of dilation of this very calcified lesion, and it does not succeed. For this reason, we started with the rotablation, very difficult to cross the lesion, and then we retried with the non-compliant balloon, no possibility to expand the vessel, and then we switch to the OPN balloon, the ultra pressure balloon, and you can see this slide is, I think, most important slide, the progressive dilation of the vessel. Do not use a lot of force, be careful, but try to increase gradually the pressure with this balloon. These lesions are there since a lot of years. You cannot achieve a very good expansion in few seconds. So take your time, progressive dilating, and achieve a very satisfactory results. And for sure, we use also the balloon also to lesion preparation, and also in patients which have no possibility to be prepared in other way. You can see this patient was transferred at our institution because we are a referral center for very difficult, complex risk and indicated procedure. Distal left main, very diseased, a lot of calcium, no option to bypass because there is stent preceding, previously implanted up to there, chronic occlusion of distal LC6 and almost occluded RCA between two stents that had been implanted in the past. So the first thing we did, we gave a little bit more flow in this vessel. It means that we performed, first of all, a rotablation of the RCA, and then we scheduled the patient for a staged procedure, and the patient performed this staged procedure a few weeks later. You can see still there the results after the first intervention with the OPN that was expanded up to 35 atmosphere, and the patient went well. This is the final result, and a few weeks later the patient presented again at our institution to complete the revascularization, and you can see this was the vessel that we have to treat. This was the control ancho that we performed a few weeks later. You can see that is a reversal of the collateralization for the LCX. Here the LCX, due to the disease of the RCA, was antegradially reperfused in this way, and after a few weeks, by opening the RCA, the LCX was reperfused retrogradally. So what we did, we performed the recanalization of the LCX, and then we faced the very, very huge and calcified disease of the distal left main with a super high pressure balloon by using two guide wires in order to have such amount of plaque modification with the scoring. So you have no scoring balloon existing on the market that can achieve this kind of pressure. You have this balloon, you put a wire between the balloon and the vessel wall, and you can have a super high pressure scoring that is nothing that is comparable with this kind of balloon. So you can see the final results, complete revascularization. The patient did very well, and just for you, we used the super high pressure balloon. We performed a randomized trial to understand what is the impact of a lesion preparation with super high pressure balloon against a scoring balloon in terms of final stent expansion index. We have completed this randomized trial, multi-center trial, with an imaging primary endpoint in terms of stent expansion index. And I hope that by the next meeting or the next webinar or webcast with Professor Seth, I will be able to show you the results. This paper is under review in a peer-reviewed journal. So, just to give the possibility to the next speaker, my colleague, to talk about the technology of vascular lithotripsy, I want to spend the last few slides, very few slides, on the the possible concomitant use or competitive use between these two technologies. I will not describe this technology because it will be the mother of the next speaker, but I will just, and I will not discuss about the literature available on this technology, but I will just to share with you this patient, a patient that received two stents in the past in the mid-LID, the mid-LCA with a huge amount, a shoulder of calcium. You can see it also on the screen. That is a very huge amount of calcium surrounding the vessel, and there was a clear stent under expansion at that point. There was a functionally occluded distal RCA, a completely occluded PL, and the patient was referred to us to an option in order to be able to expand this kind of stent. We decided to use the shock wave, I mean the vascular, intravascular lithotripsy, and in the next slide, sorry. And the next slide, you can see we use the 4.0 shockwave balloon, 18 pulse. 4.0 is the maximum diameter of the shockwave balloon, and we cannot expand the vessel, but we decided to use a 4.5 OPN balloon, I mean ultra pressure balloon, after the use of the shockwave, before starting to approach the distal occluded vessel. And we can see that we can achieve, maybe together with the shockwave balloon, we can achieve a very good result. And as you can see in the next slide, we had the possibility to implant it, to expand the vessel, to implant a onyx stent 5.026 to drug-eluting stent in the descending posterior and the distal part of the RCA, and a very good result. Finally, after 16 years of attempt to expand the vessel. So the possibility to a competitive treatment with OPN or shockwave will be the object of another randomized trial. We are starting with it. We are trying to have the funding for it, and we compare intravascular lithotripsy against the super pressure balloon in severely calcified lesion. And then we will have a primary endpoint, an imaging endpoint, and I hope to have the possibility to share with you in the next future the results of this trial. So, ladies and gentlemen, thank you very much for this opportunity. My conclusions are: resistant coronary lesion, limit the safety and efficacy of contemporary DES therapy is a problem. Balloon angioplasty is limited with resistant lesion because a result, and the most part, due to non-compliant balloon angioplasty, I'd like to add, resulting in insufficient lesion preparation before DES implantation. Ultra or super pressure balloon angioplasty can dilate the vessel up to 55 atmosphere. You now have to reach this kind of atmosphere. You have to expand the vessel, and to prepare coronary segment to drug-eluting stent implantation, studies are ongoing, and I think that also vascular lithotripsy represents an emerging technique, very interesting, but in need of further investigation. Thank you very much for your attention.
Yeah, thank you very much. Because time is running fast, we have a limited time for question and answer, very limited to only, I guess, not more than 3 minutes. So I will ask our first panel, Dr. Ravinay, to comment on Dr. Cassese on his lecture, especially for road bladder followed by ultra high pressure balloon. Dr. Ravinay, and then followed by Dr. Zhang, Dr. Singh, and if time is enough, please.
Look, I think Sal's really touched on some of the critical challenges we face in the cath lab dealing with calcified lesions. I think the utility of high pressure appropriately is so important. I think we've all utilized super high pressure balloons to really overcome challenging lesions. The challenges we have in the cath lab are the combination of delivery of the device to the lesion, getting optimal expansion, and then the risk of rupture and subsequent consequences. So I think you've touched really nicely on the utility of these devices. Certainly in my practice, and I think the panelists, I'd be very intrigued to see what everyone else in the panel uses. I think we use a combination of super high pressure balloons in combination with ancillary atherectomy devices and lithotripsy balloons now, which we'll hear about. And I think the challenge is to be able to do things safely and get the most optimal result. We, for 2 or 3 years, we're exclusively using high pressure balloons, super high pressure balloons with excellent results. And now that we've got lithotripsy, it's changed the safety paradigm a little. So I'd be intrigued to hear from the rest of you to see how you choose the various devices in your practice.
Congratulations, Dr. Cassese. Excellent presentation and cases. So unfortunately in China so far, we don't have this ultra high pressure balloon for severe calcified lesions. So from your presentation, I have 2 questions. if time is okay. So first is how about the safety concern? Because I noticed this balloon can up to 55 atmosphere. So I means, is there any vessel perforation of these cases? Another question is, I noticed from these 7 cases, I think almost every case is guided with the angel. So my question is how to sizing the arterial balloon? Because according to the study, we all know, if we use the intracoronary imaging like IRIS or OCT, we can accurately sizing the vessel and the selector property of the balloon. Thank you.
Very quick answer. Thanks a lot for your question. First of all, regarding the risk of perforation, a safety issue is very important. We recommend in our practice, because there was a learning curve, up to now we have 2 vessel perforation in more than 500 patient treated with this kind of device. And in both cases, there was a problem of over-dimensioning of the balloon. We suggest to use a balloon 0.5 millimeter smaller than the vessel. And it is a safety issue. And you don't have to reach the 55 pressure. You have to reach gradually the pressure that expands your vessel. And for sure, the second answer to your question, the threshold for an imaging should be as lower as possible in this kind of patient. And for this reason, we try also to communicate the importance of OCT, because you can see that both the randomized trial we are designing are with OCT. So the imaging should be an integrated part of the intervention of this kind of lesions.
Is a question from the floor from Dr. Naveen from India to Dr. Cassese. He asked about your first case. He asked about instead of rotablator, how about if intravenous lithotripsy is an option for your first case? If you remember your first case from your presentation. That's the question from the floor.
Very fast answer. It could be an option, but you can see the extension of the calcium. You know that lithotripsy comes out with 12 millimeter, but I would like to speak about this technology because it is the matter of it's the subject of the next presentation. And the crossability, you know, every device that you use for calcified lesion, you have to pay something for the crossability because you achieve because you have another objective. So also the crossing profile of the lithotripsy balloon is not so user-friendly. And also the ultra-pressure balloon has a little bit bigger crossing profile as a normal non-confined balloon. For this reason, we very often we use the combination of rotablation and super high pressure balloon instead of lithotripsy.
Thank you very much. Because the time is past now, I will move on to second speaker, Dr. Michael Lee, on intravascular lithotripsy. And then for the panel, Dr. Singh and Dr. Khalid will do the next for the comment. Michael Lee, please.
Thank you, Damras. Thank you, the Ashok and the Virtual Education Program Committee of APSIC for your invitation for me to talk on the best practices in intravascular lithotripsy for heavily calcified lesions. Professor Seth has addressed this. We don't really want to touch on calcified lesions because they always end up in worse outcomes for the patients. There are more death, more MI, and more revascularization in the future when we see calcified lesions, especially in very severely calcified lesions. We now very much adopted this OCT-based calcium score to tell us whether the vessel is heavily calcified or not. So what we are looking at is the, first of all, the calcium angle at the arc of the calcium, more than 180 degrees, then you might end up in a worse outcome. And then the thickness, if it's more than 0.5 millimeter, or the length of the calcified lesion, more than 5 mm. If you add up all these characteristics together, it will predict a much worse stent expansion, a much worse clinical outcome at the end. So these are the patients that we should pay particular attention to and try to modify the lesions. You've heard of the OPM balloon. There are a lot other NC balloons, scoring balloons, and other atherectomy devices. But today I'm concentrating on the intravascular lithotripsy. What this IVL shortwave balloon did was it will actually generate electrical energy by the generator, pass along this catheter all the way to the emitters. And the emitters will actually cause expansion and collapsing of the vapors inside the contrast saline medium. And this rapid expansion and collapsing of the bubbles will create micro explosion and sort of creating short bursts of sonic pressure waves. And this wave will travel along the vessel wall and cracks, fractures, preferentially the intimal and the medial calcium. What you can produce is through this micro explosion of around 50 atmospheres of pressure, which is sort of more or less equivalent to an OPM balloon of 55 atmospheres. So it's a very, very powerful sort of energy transmission all the way to the calcium. This balloon is a little bit bulkier than the usual semi-compliant balloon that we are using. 6 French compatible. Usually we would choose a balloon to vessel ratio of 1:1. What we will do is we inflate the balloon at the lesion to 4 atmosphere, and then we deliver the energy, 10 pulses of therapy each cycle, and the maximum number of cycles that one catheter can deliver is 8 cycles. So after this delivery, we actually inflate the balloon to 6 atmospheres and then deflate the balloon and then take the balloon out. With this a little bit bulkier balloon, we need a reasonable lumen before the this balloon catheter can pass through. The evidence has been provided by the DISRUPT-CAT 1 and 2 trial. It has shown the device to be both safe and efficacious. DISRUPT-CAT 3 is just a global IDE trial. Enrollment has just been completed, and we are waiting eagerly for the results. DISRUPT-CAT 4 is the Japanese pre-marketing trial. So a recap of the DISRUPT-CAT 1 and 2 registry is that it's shown to be a very effective ways to modify calcified vessel and end up in 100% stent deployment with a high rate of acute gain and low residual stenosis. It is very safe. There are no major complications, including perforation, embolization, slow flow. And if you look at the OCT sub-study, the calcium was fractured in more than 80% of the lesions seen by OCT, and ending up in full stent expansion afterwards. So how it works is usually you can see it visually when you look at the balloon. The balloon actually, the calcium will produce a denting of the balloon, but as you give energy with each pulses, then the balloon will get expanded, and then you know the calcium has been cracked. If you look at the OCT of the vessel after this IVL shortwave balloon angioplasty, you can easily see a deep fracture of the calcium along the along this calcium. You see these fractures which can not be achieved by really many other atherectomy devices. This will actually end up in good stent expansion and position at the end of the procedure after stenting. The IVL shortwave balloon is very good for concentric lesions. When it comes to eccentric lesions, then you might actually require a lot more energy to crack the lesion, mainly because, first of all, the emitter is further away from the calcium, as seen in this picture as compared to this. And the energy it actually produces will actually be dissipated through the soft tissue instead of reflecting back to the opposite wall like in concentric calcium. As a result, more pulses, more energy might be needed for eccentric lesions. However, it has just been presented in the PCLE course in April that when they take up the eccentric lesions in the disrupt CAD 1 and 2 studies, you can see that the number of IVL catheters used and the number of pulses delivered are actually not much different between the eccentric and the concentric lesions. And you end up in more or less similar mean stent diameter, residual stenosis, very, very favorable result, and very good acute gain. And the MACE rate was, again, very, very similar between the eccentric and the concentric group. So this might actually tell us that IVL for eccentric lesions might actually be also possible and equally efficacious. In-stent restenosis is the Achilles heel of all interventional cardiologists. There are not many ways to treat the expander stent when they present with ISR. We can use a rotablator to ablate the stent, but the theoretical advantage of IVL was that it actually can cause less trauma, but resulting in a better result. However, this is still an off-label use, and the evidence was mainly supported by this different case series, case studies. Biggest registry I can find is this SMILE registry, when they recruit 39 patients with very, very complex in-stent restenosis. Some of them also already have 2 layers of stents. But you can see that the number of pulses given for all these patients are actually very reasonable, 56, 57. And the resulting minimal stent diameter was again very favorable, 3.2, and with very good acute gain. IVS for ACS and AMI, again, not much evidence available, but there are some case series reports with the use IVL in ST elevation myocardial infarction. And this European observational registry show that even though they have included about 30% of patients presented with ACS or AMI, they can actually end up in very similar success rate, as well as a very low complication, very low MACE rate at the end of the procedure. So again, IVL in the setting of ACS or AMI, especially in very calcified vessels, might be actually also safe and efficacious to be used. Nowadays, we more or less follow this sort of algorithm when we come across moderate severe calcification. So we will look at the imaging result to tell us what the calcium score is. And if the score is low, we can actually simply treat the lesion with a high pressure NC balloon. Or if the calcium score is high, we go ahead, we use the lithotripsy balloon. Of course, as I mentioned, you have to have a lumen to use the lithotripsy balloon. If the lesion is uncrossable or just able to be crossed by a guide wire, we often will use, first of all, the rotablation or the orbital atherectomy. If there's an optimal result, we can go ahead and do stenting. If there's suboptimal result, we will add on lithotripsy balloon. We have been using this lithotripsy balloon since May last year in Hong Kong. So far, we have used more than 500 in the coronary setting and about 12 balloons in the peripheral intervention. So we've treated a huge number of different kinds of lesions, diffuse, concentric calcium, osteo lesions, bifurcations, CTOs, STEMIs. We have used in about 20 cases of ISR with incomplete stent expansion. And then combination use, and actually we have also used some in the iliofemoral region to facilitate our TAVI procedure. So this is one of the cases that we would actually use combination therapy. It's a very tight CTO cross with a wire. There's no way the shockwave balloon will cross, so we use upfront rotablation to modify the lesion first, and then went in with a 2.5 and a 3.0 shockwave balloon. And afterwards, you can see this deep cracking, fracturing of the calcium, of this deep calcium. And then after stenting, you can see very, very reasonable result of stenting with good stent expansion and apposition. This is a huge RCA with very, very tight stenosis, as you can see in the OCT run, very thick calcium, 1.8 millimeter thick. So what we have done is we use an orbital atherectomy to modify the lesion, low speed at the distal part and high speed more proximally, and then 2 shortwave balloons, 3.0 and 3.5, to further fracture the calcium. And you can see this beautiful fracturing of the calcium at the end of the ballooning. And then after stenting, you can see a very, very good result of stenting, and with good OCT results showing us good stent expansion and apposition. As I mentioned, shortwave for peripheral is also useful to help us with the large bore catheter device. This is a case use the shortwave to shock the iliofemoral artery to facilitate impeller support the PCI. And Carlo Di Mario has shown beautifully that it is also possible to facilitate the transfemoral TAFI access procedure. And this is our case when we see this thick calcium, very small lumen iliofemoral artery. We have used the shortwave M5 balloon 6x6 millimeter, and then it actually facilitate us to pass through a 14 French E sheath through this very calcified iliofemoral artery, and then followed by the Sapien S3 valve to finish our TAFI procedure. So this is our flow chart, or our summary of when to choose what kind of atherectomy devices. So when we come to the shortwave, you can see that we use mainly for deep calcium, concentric calcium, or when we have osteo left main RCA lesions, a bifurcation with significant side branch. We have to protect the side branch, and then we would probably choose to use the shortwave balloon. So in conclusion, I think calcium is still one of the worst enemies of all our interventional procedures. We need to modify this calcium to optimize our result, and intravascular lithotripsy has been shown to be safe and efficacious to modify these very calcified lesions. Imaging is very important, IFAS or OCT or FDI, and sometimes we need combination atherectomy therapy. Shortwave for the peripherals can enhance our impeller or TAFI procedures, and in the very near future, we hope we will have this shortwave balloon to treat our severely calcified aortic valve, aortic stenosis patients as well. This is our CHIP and our communication meeting, virtual meeting in November. You are more welcome to come and join us. Thank you for your attention.
Thank you very much, Michael. It's very enlightening for the intravascular lithotripsy, especially for some other country that have no advantage of this using this device. Right. I may ask our another two panelists, Dr. Ramesh and Dr. Khalid, to give a short comment or question, and then we go back to both speakers for the something like cost effectiveness of both high pressure, ultra high pressure balloon and intravascular lithotripsy for heavily calcified lesion.
And Damras, we'll also continue this discussion for another 10 minutes. We don't mind going slightly 5 minutes extra on this session, because I think a lot of clarification from the audience may be needed. We had 1,900 registrants for this this Congress. So please carry on and also clarify whatever comes in from the audience.
Okay, Ashok, give us 10 minutes. So Ramesh, sure. Khalid, and then go back to both speakers, Dr. Cassese and Michael.
Thank you, Dr. Damras. Hi, Dr. Lee. How are you?
Hi.
Yeah. So I think your talk is fantastic. I mean, so easy, so clear to understand. Well, you know, we all use all kinds of balloons to actually prepare our lesions, and I think lesion preparation is of paramount importance. Sometimes you may see on the angiogram there's not much calcium, but actually it's a fibrotic lesion, and we should not underestimate our lesions. One of my concerns with IVL is the fact that it's costly. certainly costly in Malaysia, and in Malaysia we don't have the ability to reimburse that much unless they pay. And you know, in order for us to use IVL, we also need to prepare the lesion well, and this may incur further costs like OA or rotablation and things of that sort. And I believe, and I think I've heard your lectures before, I don't think you've had any perforations or significant perforations with this device before. I also believe that you use quite a bit of OCT or imaging to guide your balloon size, and I understand your ratio is 1:1.
Yes.
Now, my concern is, will I be able to cut my cost and not use imaging? And you know, if there is an indication to use IVL, do you think it's safe enough, and do you think I can safely size it according to the angiogram, a 1:1 ratio? And do you think that's advisable?
Well, thank you, Ramesh. First of all, we haven't really seen a perforation as a result of the use of shockwave balloon. We see sometimes a rupture of the balloon, but it doesn't end up in rupturing the coronary artery. So it's very, very safe to use, I would say. Imaging, I think for us, is very important to tell us the severity of the calcification. Without imaging, you won't be able to know the depth of the calcium or the art of the calcium, whether it is circumferential or eccentric. So the use of imaging sometimes will actually save us the shockwave balloon. Like if we see just a moderate or a very mildly calcified lesion, not to the degree of 180 degrees art or very, very thin calcium, then we can simply use an ordinary NC balloon, scoring balloon, instead of the shockwave balloon. Sometimes it might be a cost saving for us. But in case you don't have the availability of a lot of imaging facilities, I think by angiogram to choose a balloon size is still acceptable. And we see that has been done in a lot of the European centers, and it has ended up in very good results. The important point is you see the expansion of the balloon. So you give the shock, you give the pulses, and then you see the expansion of the balloon. If the balloon does not expand, then you give more shocks instead of treating half-hearted every here and there. So we would like to see full expansion of the balloon before we call it a success.
Sure, thank you. My next question was actually, what's the reason the balloon actually ruptures, and in your experience, what are the consequences of a balloon that has ruptured? Does it lead with no slow flow or no flow?
No, you know, we inflate a very low pressure, 4 atmosphere, and then deliver the shock. Sometimes we see perforation during the shock, but sometimes actually it's after the shock when we inflate the balloon to 6 atmosphere, and then we will see this perforation at that atmosphere. I think mainly because the calcium, some of the calcium are actually sharp calcium nodules that are very, very difficult to yield, and then it will actually indent into the balloon and cause rupture of the balloon. But even with this rupture of the balloon, we actually have seen very few, maybe 2 or 3. But it does not end up in any of the slow flow. It does not affect the flow at all. So luckily, and no perforation of the vessel. We have seen one dissection of the vessel as a result of this, but nothing really major in the other cases.
Before we go on to Khalid, can I just comment on this aspect? Because we've got a good experience of shockwave as well as ultra high pressure. The ruptures, we've had ruptures of the IVL. When it ruptures during the pulses, it's usually when you've actually delivered 60, 70 already pulses and it's towards the end in a very heavily calcified lesion that it does rupture. But if it ruptures during pulses, it does create extensive dissection. The reason for that is, but not perforation, because the reason for that is the pulses are coming at close to 50 atmospheres while they're encased, but that's the sort of reverberation that's happening. If it ruptures, it just leads to dissection, and we've had to cover long segments. When it leads to ruptured after pulses are given, and when we go up to 6, as we've had in another case, that does not lead to extensive dissections. You just see the leak of the contrast and that's it. So we've had 3 ruptures, and 2 of them extensive dissections where we've had to really extend the length of the stents by another 4 or 5 centimeters. But they have been innocent ruptures as well. But it's a safe device. It's actually a very user-friendly device. And I would actually recommend it for especially large vessels with deep calcification. The other aspect, eccentric lesions are always very difficult to treat with any device, as you know. And with and I'm a great proponent of ultra-high pressures, but the disadvantage in eccentric lesions with ultra-high pressures that you're just going to blow up on the normal side. And especially on an angulated segment, perhaps create perforations if you're trying to just try and move the eccentric lesion away, and you're really affecting the normal side, an expansion towards the normal side. If you deliver enough pulses in an eccentric lesion, and the eccentric lesions need more pulses, you actually do get an expansion which is far more uniform with IVL followed by stent implantation rather than ultra-high pressure followed by stent implantation in eccentric lesions. Those are my comments.
Thanks, Ashok. Looks like there's a lot of interest in this topic. Can I just ask some of the questions pulled in?
Before Jack, I would like Rashid to comment because he's actually on the panel there, Khalid Al-Faraidy. I would like Khalid to comment before we go on to your comment. So Khalid, yourself, please.
Yes, thank you, Mr. Ashok. Thank you, Professor Lee, for this interesting talk. I'll just emphasize that what you said from the last, which is the importance of imaging. If you're going to use these devices or you're going to use rotablator or you're going to manage heavy calcific, I think the role of imaging, either IVUS or OCT, is very crucial here if you wanted to use it. Majority of this lesion we can manage with the only high pressure balloon or cutting balloon, but if you're going to go advanced to rotablator or shockwave, I think complementary imaging is very crucial for that to use. We don't have here in my cath lab the super high pressure balloon. I'm very interested to try it or to see more about it. But we have the rotablator, the majority of the cases. Recently, we used the IVL. We have very successful results, especially in stent restenosis or patients who have under-expanded stent and behind it calcium, where it worked very well to expand, to crack the calcium behind the stent. It was very useful. My question to you, Professor Lee, I have 2 questions, quick question. Would you routinely, we know that we inflate to 4, then we leave the shock, then up to 6, then we deflate. Would you routinely do both there with high pressure balloon after that, before stenting, or you don't? That's my first question.
We usually, depends on the size, the lumen of the vessel. If we think we can cross with the shockwave balloon, then we would actually primarily do a shockwave balloon. And if we see good result with expansion of the shockwave balloon, we can go ahead and do stenting right away. But if we, it's not really the very good semi-compliant balloon to use. Sometimes it's difficult to cross. Then we might use a smaller balloon, smaller NC balloon to first of all create a lumen for us to use the shockwave balloon.
So we have questions here from Hong Kong, Philippines, Australia, Malaysia, India. So I think that we should address some of those questions which relate to, so can I bring those questions in? So first one, and be brief, this is to both, while all of us have good expertise and experience around this, but I'd rather Dr. Cassese and Michael Lee answer these questions. And of course, anybody can come in if they've got an added brief comment to it. The first one is, do you recommend using IVL for ostial left main lesions, or would you prefer rota for the same? So that would be for Michael.
I would prefer IVL balloon.
Correct.
This was my question, actually, my second question to Dr.
Okay.
So you got that answer.
It's actually easier to use, and less complication will be foreseen.
But you have to leave the balloon for 10 seconds. If patient have severe LV dysfunction, might not tolerate, is it not?
Yes, that's right. That's right. But the cracking is actually very, very soon. Yeah. The second and the third pulse, you will see the cracking of the
correct. And you can be cumulative about the pulses. So you don't have to deliver the 10 all at the same time. You can deliver 5 even, and you can deliver to 10. But 10 is fairly, 10 seconds everybody tolerates. So now, is it safe to use IVL after balloon dissection? So that was another question. Is it safe to use IVL after balloon dissection? Absolutely, I'd say.
Yes.
There is no...
As I mentioned, we try to expand the lumen if we think the IVL cannot pass, so it's safe to use.
So a 2 millimeter balloon is what you use to create enough space for the IVL to...
Yes, that's right. 2 or 2.5, yeah.
So, and in those uncrossable lesions, do a rotational atherectomy first with a 1.25 or a 1.5 burr, which will get you enough to cross an IVL and then use the IVL. Right. What about the patients where there is no OCT evidence of calcium fracture after IVL? Is it a failure?
Sometimes we need to repeat the procedure to create that fracture. It takes time, it takes pulses, it takes energy, especially for very, very deep hard calcium.
Deep, hard and eccentric calcification. And by the way, calcium nodule may not respond to IVL.
That's right. That's right.
So Dr. Seth, can I make a comment here?
Oh yes, Praveen, do. You're a great expert at it. Please go ahead. No, you are.
I saw a very interesting case shown by Dr. Cassese, where after the IVL we had to go for an open NC balloon. In fact, I have a couple of patients where we did, we finished all the pulses with the IVL balloon and it was not responding. And then finally we went with the open NC, go to very high pressures, and then we could crack it. So maybe it just loosens it a little bit, and then we can do it later on with that, because it just still needs some pressure.
Oh, you're so right, Praveen. And the more the eccentric lesion, I think IVL first and OPN followed. And I have a number of cases like that. So I always believe these are complementary rather than competitive, even though Dr. Cassese is going to do a great study as a comparison. But in some cases, which are very complex, these are complementary rather than competitive. Thank you for that comment, Praveen. And have you used shockwave therapy for unprotected left main artery lesions? I think the answer to that is yes, of course. How do you choose? And I'll ask Dr. Cassese this. How do you choose the patient for device? In that we've got more tools for calcified lesions. Any algorithm? While Michael's shown an algorithm, Dr. Cassese, Salvatore, yourself, what is the sort of algorithm? And now, I think I'd like you to be balanced between the use of rotational atherectomy or atherectomy, ultra high pressure, and IVL.
I completely agree. I thank also Professor Lee for his very great presentation, because I think that, and you for organizing this very thoughtful discussion. In the daily practice, the crossability of the lesion is the important thing that can switch to one device or another. But first of all, I would like to say there is the possibility, and it should be also the possibility to understand through the imaging which device is the patient will profit the most. Because if you can see eccentric, nodules, eccentric, you can switch to one device or another, pending the crossability of the lesion. Because I think that sometimes we face also some lesion we are not crossable with the microcatheter, and then you go through with the rotablator. So I think that all these devices, the super high pressure balloon, the IVL device, they are paying something in terms of crossability. So the crossing the lesion is the first part. You can also achieve the crossability of one of these two devices with a non-compliant balloon, a little bit with a small diameter. But I think that the crossability is the turning point of our procedure. And regarding the combination of these devices, I completely agree that these devices can be competitive if they will competitive or will one non-inferior to another with a randomized trial that they can demonstrate this. For sure, also in Germany, the costs are an important issue, because for extensive lithoplasty of a vessel, you need 2 devices, and maybe it should be it would be a problem from a cost perspective. But for sure, I think that imaging is key point, crossability is the second point, and then at the end, the final imaging control is another key point, because I don't know if Professor Lee makes some post-dilation with IVL, but with OPN, we make a lot of post-dilation. So it is something on a balance between the two devices. I think that is something that is more pros a OPN balloon than IVN. For the lesion preparation, we have to understand which is competitive, which is you can use concomitant. For lesion post-dilation, maybe at the moment, but I don't know, in the experience of Professor Lee for vessel post-dilation, maybe I think that IVL is a little bit less useful than the OPN.
So now finally, I'm going to, and I know that we are over time, but that's not the issue. We want a good discussion, and we want to convey the discussion rather than the talk. So we don't mind even going 15 minutes over time on the whole symposium and the webcast, because at the end of the day, it's for
something.
Yes, please go ahead. And Praveen, before you go ahead, can I just present a final question from the audience, and then I'll have your question, your comment. So the question, which are 2 or 3 have asked, is the same, which says, how high is the risk of vessel rupture from a OPN ultra high pressure balloon? You see, that's the biggest concern which people have. It's a psychological concern. And before Salvatore comments on that, let me just comfort everybody on the fact that vessel rupture is a consequence of size, not a consequence of pressure. And you already heard the fact that if you're appropriately sized, which means that I'd go one step smaller on an angiographic assessment, or even an IVUS assessment is far more accurate. But you know, your angiographic assessments are always smaller than the true lumen of the vessel itself. Now, if you actually go on your angiographic assessments are smaller, you can actually go up to 45 atmosphere and not rupture the vessel. That is well understood. So it's the consequence of the size. It's the dog boarding which gives ruptures. It's the oversizing at higher pressures with a compliant balloon or with a stent balloon which gets ruptures. And the second aspect I want to comment is, yes, that these balloons can also rupture. And they can be a spicule, they can be unpredictable ruptures. It doesn't necessarily mean that they rupture at only 50 atmospheres. We've had rupture of the balloons at 40 atmospheres, but they really rupture less than 40 atmospheres. So I think you've got to be sensible at the time you take it up. Beyond 20 atmospheres, you go up sequentially, and every 2 atmospheres watching the size and watching the vessel. And you then take it to a particular, you don't have to take it to 45 in every patient. You take it to 30 to 35, watch it and stay there for some time, and your lesion would give way. So it's not as if you want to do 45 atmospheres and 50 atmospheres in every patient. I think that's what I wanted to comment. Cassese, yourself, and then Praveen Chandra.
I completely agree. It was also the reason for the 2 comments that I made during my presentation. Please try to not use the 1-to-1 dimension for the lesion preparation. Go preferably ½ millimeter smaller diameter than the vessel, and then put the pressure slowly, gradually. This vessel we are facing off, they take a lot of time to be calcified. We cannot force this stenosis in few seconds. So take your time, explain the patient that he will they will have some pain during the inflation. You know, that is something that requires time. That's the most important part of the story. And then please do not over-dimension. Take your time and speak with the patient. Tell the patient that they have to resist during this vessel are opened.
Great. And Praveen?
Yeah. So I just want to, add to first that point of rupture, because many times people have this apprehension and they keep asking whether it can rupture the artery or not. So up till now, I have not seen any rupture. I shouldn't say that it never happens, but certainly it hasn't happened up till now. And as you said already, that the sizing is one of the key issues in actually preventing the rupture of the arteries. That is number one. The second is that, we were talking about very, very heavily calcified total occlusions. So what is the approach in that? In that, I have seen the approach of complementing all these technologies together. For example, 99 or 100% total occlusion, very calcified, nothing, not even the rota wire goes in. You go with a specialty wire, and the the microcatheter is not going in. So what we've started doing is use the Nick Nano 0.85 balloon, which goes to slightly higher pressures, create a passage, and then put the rota wire, then do the rota, and then followed by a IVL. So it's a full, one
complement
after another, complementing each other, and then you can successfully do this procedures.
Great. I think we will go on to the next because we have a number of questions which we'll take up, which could get answered during the cases, but we'll certainly have another further discussion. So Salvatore, I hope you're not leaving us because you're going to actually see a lot of ultra high pressure cases.
I'm here to stay.
Excellent, because there's going to be subsequent discussions during as well as after the case presentations. Normally this is 1.5 hours, but because we want to clarify all across, I mean, the questions here are from Sri Lanka, Mauritius. I have questions from Iran. I have questions from Afghanistan. So I just need to answer all of this. Therefore, we will go on to the next, which is my most difficult educational calcified lesions. I'm going to firstly introduce Ramesh Daggubati and then hand it over to both Jack as well as Ramesh. Jack from Singapore, you all very well know, but Ramesh is a very leading thought leader in interventional cardiology based in the United States, in New York itself. He's on key positions, key leadership positions in SCI and many of the intervention societies of America and United States. He's been very integral part of teaching, education, and other activities in the United States and for Asia Pacific region, and certainly for India. He's an expert in all devices and has really been a true friend for last many years. With that, Ramesh, I hand it over to you, and Jack, who's integral part of APSIC as well as the president of the Asia Pacific Society of Cardiology. So over to you, Ramesh.
Thank you very much, Ashok. I really appreciate this opportunity to participate in APSIC and the difficult calcified lesions from the United States. I bring in all wishes and to be safe for each and every participant as well as the speakers. So I think we're going to go ahead and start. I just wanted to introduce Jack. You want to say a few words?
No, I'm good. Actually, I was just coming to also narrate the questions. I realized there was so many wonderful questions from participants, and I think the questions maybe you can address in your case also is how to fit the algorithm in the applied case, and to address some of the concerns for the audience as well that was well narrated by Ashok. So maybe you can start.
Thank you very much, Jack. I think Ashok has asked me to also show one case. I think we have actually the second session is my most difficult and educational calcified cases of 3, but probably you'll get one bonus as well from me. So I'll go ahead and show you this right away. So without wasting too much time, I think you can see my screen now. So can you see my screen?
Yes, we can. Please go ahead.
Okay, sounds good. So these are my disclosures. So here's an 86-year-old gentleman with severe aortic stenosis, coronary artery disease, PCI, and with paroxysmal atrial fibrillation, a mean gradient of 56, ejection fraction 60, mild MR and AI. And he had come in with the class 3 symptoms of dyspnea and exertion. Due to his age and comorbidities, he was felt to be a TAVR patient. And so we looked at the echocardiogram here. You can see heavily calcified aortic valve. And so there's some mild AI and MR, but heavy calcified valve with mean gradients here, as you can see, about 55 millimeters of mercury. And so this is no doubt it's a severe AS. And so this is how we have done with the TAVR, and you can see a 34 millimeter TAVR was placed, and I'll show you those other slides. But with some paravalvular leak, which we again ballooned that, and with the 24 balloon, Atlas balloon, and got an excellent result. But that was not the story for this patient. How did we get access, I think, is the most important one. Here for this gentleman, the limitation was small internal external iliac arteries, and you can see in the common iliac artery as well on the left side is very small and very prohibitive on the left side. On the right side, we thought, okay, this is 4.9 by 5.3, or what we'd like to have is 6 or 5.5. So we said, okay, maybe the dilators will work. And so we first got access on bilateral femoral, and we did a distal iotogram with runoffs. And you can see here in the common iliac on the left side is very heavily calcified. And on the right side, there is a minimal lesion. But the external iliac arteries are where here you can see calcification. And so we said, okay, let's try a Coombs dilator, serial dilation and dilators. And so the 10 French dilator went easily. And after that, we hit a roadblock and it wouldn't pass. Okay. So only up to 10 French we could go up. And so then we said, what is the therapies in our usual algorithm for us is try dilator. If the dilators do not work, don't push too much, because you can actually cause more damage to the peripheral arteries. So then we go ahead with a shockwave 7060 balloon, and multiple pulses were delivered up and down, actually even up to almost a distal aorta and all the way to the external iliac artery. And we have a small sheath here through which we went over a run-through wire and the balloon and delivered multiple pulses. And so as you can see, once actually you go up to 4 atmospheres, as Michael Lee mentioned, you go and deliver the pulses, but then actually you can expand. As a regular balloon, you can go up to 8, 10 atmospheres and it doesn't rupture. But don't deliver at 8 or 10. You should deliver only at 4 atmospheres of pressure, and then you can use it as a regular balloon as well. So then actually an 18 French dilator and the sheath now was very easy to pass. And the rest of the story, actually, as I showed you, is very simple and easy to perform once you get the sheath, crossing the aortic valve with the Lunderquist, with the AL1 and straight wire exchange for Lunderquist. And we delivered that 34 millimeter valve without any problem. So here's the completion angiogram. It looks okay. We delivered a MANTA. Here there is some slow flow for that. But so we did a peripheral vascular ultrasound so that the right CFA, as you can see, here is the MANTA. So it appears that it is closing some. That's the foot process inside. But there's still some flow across the peripheral artery disease, across the CFA. So this is a successful way of doing still transfemoral. Obviously, alternate access could be done as subclavian or carotids, but I think it is still transfemoral has been shown to be superior to other alternate access. So here I just wanted to show you one case, and then we'll move on to the presentation by Ashok Seth. So it's my now great pleasure to introduce to the master of interventional cardiology. Ashok Seth doesn't need an introduction. He's the president of APSIC and has been multiple leadership roles, including a board member at Sky as well. So I think I welcome Ashok, and please proceed with your presentation. Thank you.
Thanks, Ramesh. That was a fantastic case, short and sweet. Wichim, do you have any comments?
No comments. I'm just going to leave Ashok Seth to go on.
Okay.
Good.
So maybe if there's no other comments from the panel, we'll have Ashok present his case. I think Ashok is having some issues with his Wi-Fi. Can I just pick the brain of Ramesh and Michael? The lithotripsy technology they are pitching to apply in the aortic valve as well. What are your thoughts on that?
Yeah, I think that'll be a great thing if you can actually make a large balloon and as a size of 20 or 25 and up to 26 millimeter balloon and deliver at 4 atmospheres. The risk of a severe AI probably will be less. Now, sometimes annular rupture has happened to me as well. When I went with the 26 true dilatation balloon, I did have a aortic annular rupture. So those risks of rupture will be removed when you go to only 4 atmospheres, so you don't have to really compress, dilate the aortic valve that much. I think that will be great.
Can I ask a question?
I think it's a great concept, as I mentioned in my last sentence in the conclusion slide. I think we heard some presentation from Darren Mylett about 2 years ago in the EuroPCR about this shortwave balloon for the aortic valve to treat aortic stenosis. But I don't know, maybe there are trials going on. It doesn't really materialize so far. It's a good concept. I know there are a lot of hurdles to get through, but I think in the very near future, it should be available soon, hopefully.
We hope to see some trials going on. Praveen, you have a question?
Yeah. So I was asking Ramesh as to if, because I have not used the shockwave for any femoral access issues. So in every patient who has a calcified lesion in the common iliac or the iliac or maybe even the aorta, sometimes there is a huge calcific chunk. So you have used in all of these situations, and is there any patient where you will say, okay, this is not a good one to be done by IVL and just go for another alternate access?
So our cutoff is actually less than 4.5. We have not used it, but above 4.5 millimeters, if the dilators go, we always try with the dilator. If the dilators go, there's no problem. If not, we go for IVL. And the reason is also because it's cost. It's expensive. It does add another $3,000 expenditure to our procedure as well. So that's why, if it is less than 4.5, no doubt, we don't even try any attempt. We just go for alternate access.
Thanks. That's a great pointer. So I think Ashok is still trying to get back in. If we can move on to Tegu's presentation first before Ashok. Tegu, will you be ready to present? Tegu, you're muted. Tegu, would you like to unmute yourself? We can't really hear you. You have to unmute yourself first, Tegu.
Yeah, Dr. Seth is back. If you want, Ashok is back.
That's right. No, let Tegu go on.
Okay.
Let Tegu go on. And I'm sorry, I just got disconnected from this, unfortunately.
No problem, Ashok.
No worry.
Yeah, no worry. We'll have Tegu present first, then we'll finish up with probably a wonderful case. So, Tegu?
Can you hear me?
Yes. Yeah, we can hear you now. Maybe you'd like to go to the presenter screen, slideshow mode. Yeah, okay. That's great.
Is my slides clear?
Yeah, it's good.
Okay, can you hear my voice also?
Yeah, loud and clear.
This is, oh, sorry. I want to move my slides myself. Okay, this is a halfway rotational atherectomy for treatment of angulated, heavily calcified lesion. I just want to show this case. This is not my own case. This is the very first case, the case of Dr. Sakakura from Japan, and the history of this technique started from this case report. Reported in the year of 2011, a patient with heavy calcifications and angulated tandem stenosis here in the proximal and mid-right coronary artery. And you see here that the angulated lesions is prone to perforation and burr entrapment. And this is considered as a contraindication for root ablations. So what should we do to treat this lesion? So at that time, Dr. Sakakura tried to use rota. And this is what happens. He had the burr stall here and perforation. So both serious complications. But fortunately, he can fix these lesions with a covered stent. And this is another case report. In 4 years later, patient was fixed with covered stent here, but apparently the covered stent was extraluminal. So the question is now, do we have better solution for this? So another option is, of course, halfway. Before I start discussing halfway rotational atherectomy, let me go back to this. I will discuss this technique. This is halfway rotational atherectomy. So basically, if we advance the burr across this heavily calcified angulated lesion, we may have this kind of problem, perforation and burr entrapment. So with halfway, we advance the burr here, not crossing this acutely angulated segment. And then after this, we do balloon dilatations. So quite often, not always, quite often, in the majority of cases, we can advance the balloon after we get the small lumen here, and then we can slightly dilate this. And after this, we can do another balloon dilatations or use even bigger burr to make better lesion preparation in this particular segment, and then get the vessel stented. So this is just to compare halfway rotational atherectomy and conventional rotational atherectomy. Of course, with halfway rotational atherectomy, we will have lower risk of vessel perforation and burr entrapment, and there is no guarantee that the lesion beyond the angle could be dilated with the balloon. But with conventional atherectomy, vessel perforation is of course higher. And we should also know that the manufacturer does not recommend rotational atherectomy for angulated lesions of 45 degrees or more. And this is just to show how halfway rotational atherectomy works. This is the two-dimensional model, and this is the three-dimensional model. You'll see here, even though there is guide-wire bias or burr bias, we can probably expect that we can at least have some calcium debulking in one or two sides of the napkin ring calcifications here, and this will help our high pressure balloon to dilate and to create some dissections here. And this is a three-dimensional model telling the same story as this two-dimensional model, and the main purpose is to create a small channel right there. So after this, we can use even bigger burr, because the reason is that in horizontal, with the diameter of burr in horizontally here, this is a 1.25 millimeter burr. Is of course smaller as compared to bigger burr like 1.75 or 2.0. But in the oblique burr, situation here, the diameter is more or less the same. So this may explain why bigger burr sometimes can advance across this angle, even though initially smaller burr cannot be advanced. And this is my own case. You'll see here the patient has osseal has heavy calcification from the osseum up down to the mid segment of the right coronary artery, and there is a heavy angulations here, and the osseal is critically narrowed. And I think this is not a good case for orbital atherectomy, because the lesion is osseal in locations. It is a very tight lesion, and also there is a severe angulations here in the proximal right coronary artery. And I don't think that we can also advance IVL balloon because of the big profile of the balloon, because even with 1 millimeter balloon, we could not advance this 1 millimeter balloon. So we decided to use ROTA. And this is the Amplas catheter, which provide a good backup. Of course, it is very important to stress here that coaxiality is has to be emphasized. Otherwise, we will have guide wire dissections or aortic perforations. And the guiding catheter is not intubated, and we have to advance the burr very slow with slow packing motion. And here, I use halfway rotational atherectomy up until this point only. And then we use balloon dilatation, stepwise balloon dilatation from smaller and to bigger, slightly bigger balloon. But we use only until a 1.5 millimeter balloon. And then after that, we can advance even bigger burr, 1.5 and 1.70 millimeter burr. Unfortunately, we don't have 2 millimeter burr, even though we do believe that with this big vessel, we need bigger burr. But we don't have that on the shelf. So this is the final result. Of course, there is still some irregularities. If I do have OPN balloon or IVL, I would definitely try both, any of this device. But unfortunately, we don't have. So this is the maximum result that we can get. But we are satisfied considering the difficulty of the clinical scenario. So at that time, we use bigger burr, which could pass the lesions. So this is the first case. And this is the second case. This is a 91-year-old lady presented with acute coronary syndrome. The patient has left main, severe left main stenosis, and severe double vessel disease, and on top of that, severe aortic stenosis. I think you will agree with me, the patient has massive calcifications here. This is a mitral-annular calcifications, and the left main has 90% stenosis here, with calcific nodule. The LED is heavily angulated here. This is the left main with aneurysm in the osseum. And then there is a 90% stenosis in the proximal segment of the LED. And there is a CTO here in the circumflex, but the circ is smallest and non-dominant. And the right coronary artery is shown here. There's two patent stents here in the proximal segment. Grade 2 collaterals to the LCX, but not to the LED. So what to do? See here, very critical narrowing. And this is from different angles, spider. You see here, very narrow, very critical narrowing here in the body of the left main. And aneurysm formation here. And the angle of takeoff is very acute. You see here, the angle is very difficult to negotiate. I even could not advance my wire across this angle. So, of course, if I try and fail, the patient may die on the table. You'll see here that the STS score is indeed very high for mortality and also for morbidity. Euro score 2 is also very high for mortality. And in fact, the family as well as the patients declined surgery considering her age. So PCI first or TAFI first, but both are at very high risk. So since the patients and the family declined surgery, so we decided to do PCI, telling also the family that the risk is also very high. So we used the smallest balloon, 1 millimeter balloon, but this could not cross the lesions. So we used Tornos and also could not cross the lesions. So we applied halfway rotational atherectomy. Unfortunately, I cannot advance the wire to the LED, which is very angulated, and also there is an aneurysm here right in the osseum of the LED. So we do the wire is placed in the D1. And then great care was taken so that the burr drilling was only in the left main, as shown here also. I don't want to perforate the vessel. So after this, the procedure is made easy. This is 1.5 millimeter balloon, followed by bigger balloon, and then stenting of the LEC, proximal LED lesions with the scions, and also stenting the distal LED and distal left main to the LED, and then stenting of the left main up to the osseum, and then to flare the osseum. And this is the result, the final result. I think very much acceptable. Here, this is the LED, and this is the LED. And you may remember that the distal circ was fed by collaterals from the right, but not the LED. So this is the final results, and then patient underwent TAVI. Well, this is a stage procedure. So this is a series of cases reported by Dr. Sakakura also from Japan, because he has the only person who has the most cases. This is a case report that just last year. I just want to draw your attention to the light green row here. That successful balloon dilatation following halfway rotational atherectomy is 90.5%. This is quite acceptable, considering that the lesion is very challenging. And again here, reason for halfway rotational atherectomy in its series, mainly because of angle within the lesion. This is in 62% of his patient populations. Other reasons included also diffuse long lesions and resistance within the lesions in 8%, and forced halfway due to severe acid adaptation. And this is complications of these procedures. This is a match comparison with conventional rotational atherectomy. Again, I just want to draw your attention to this light green row. Slow flow after rotational atherectomy is more or less similar to that of conventional atherectomy. Procedural myocardial infarction, peri-procedural myocardial infarction is also similar. But again here, this is also very important. Burr entrapment and perforations, two important complications that we are afraid most is 0% reported and 0% in his 56 cases. So in conclusion, the goal of rotational atherectomy in calcified lesion is for plaque modifications to facilitate stent implantations and to achieve good result without severe complications. Protablations in angulated, heavily calcified lesions tends to cause complications of especially perforations and burr entrapment. Halfway rotational atherectomy is an alternative method to use in this situation. Thank you so much. I hope I have spoken a few reasons.
Thanks. You are still jumping out of the plane all the time, I can see, based on your cases. Fantastic cases and presentation, Tegu. So there's a question from the audience. I would just like to quickly address this question by our panel before I move on to Ashok's final presentation. So the question is, for such cases, the question from Dr. Naveen, India, is OAS better in angulated calcified lesions? So maybe I can get Chim and Dr. Gaku.
And I would also, yeah, that's right. I hope Praveen is there, and Gaku and Afzalur Rahman.
Yeah. So,
I know Bashir Hanif, by the way, he just messaged because he had there are floods in Pakistan and the Wi-Fi is down for the last 24 hours. So I think we wish him well, and he's apologized.
Ashok, I managed to get on for thank you.
Oh, very
nice. Is here as well.
I've been trying to get on for last hour and a half so desperately. So thank you.
Thank you.
Finally, thanks.
Great to have you.
So to frame the question again, if the IVL balloon cannot get through, you have such angulated dia lesion, we know that atherectomy device causing perforation is bad. Maybe both Dr. Kaku and Wichim can offer us some tips and tricks and guidance about, is a halfway atherectomy rotablation superior to OAS or other methods that you can suggest? Wichim and Dr. Kaku.
Hello, this is Gaku Nakazawa. Nice to meet you, and thank you for inviting me to this conference. So I think the angulated lesion, I think OAS is sometimes has a risk for the perforation, and this halfway rotor ablation is a better way to avoid perforation. I think it's better. Also, in case sometimes OAS is also good device for the angulated lesion because of the bias. Like, for example, like Treukosol lesion. Sometimes we can use that OAS effectively, but you know, it depends on the situation, I think.
Well, I have not tried the halfway rotational atherectomy before, but certainly this is something that I will keep in mind having attended this sessions.
I think there's an important message in what didn't come out, and I just want to again emphasize for the audience. The halfway rotational atherectomy, you know, you often face a situation where your 1.25 burr, which you actually believe is a small burr and should go across angulated lesions nicely, actually doesn't. And it doesn't because I think he briefly pointed it out that while the vertical, it's the length of all the burrs are the same, and yet the design and the shape is different. If you create a halfway atherectomy, it's quite possible for your larger burr to go down the angle far more safer and better than your smaller burr. And I think that's what's those important diagrams were all about. That I think has been, I've actually believed in that. So in those situations where a 1.25 can't go, you actually upsize the burr, and you actually are safer than upsizing the burr, and that will traverse better. So that is the part and parcel of the halfway atherectomy. Tegu, comment on that.
Yes, but after halfway rotational atherectomy, I think it is also recommended to do balloon dilatations, because with with balloon dilatation, we may induce cracks, and we may create a small lumen distal to the angulation side. So after this, after creating that small channel, we can use the same burr or even bigger burr, because at the oblique diameter of the burr is almost the same. 1.5, 1.25, 1.5, 1.75 millimeter.
Correct. But doing a halfway actually makes the burr go down the curve far better in the 1.5 in the 1.5 instead of the 1.25, because it provides a space for it to actually go down. And those are one of the diagrams of this is Sakamura has done that beautiful testing around that and showed that it going around the curve. If you've done it with a 1.5, you actually have it going down much better than a 1.25.
One more question from Malaysia. Joseph Erwell is asking, Tegu, would you now choose IVL instead of halfway rotational atherectomy in these angulated patients or lesion?
Yeah, at that time we don't have IVL. Of course, IVL is a good option, but for very critical narrowing in the ostium, this is a good indication, of course, for IVL. But if the IVL is very bulky, so even 1.0 millimeter per millimeter balloon cannot be advanced across the ostium of the right coronary artery. So I don't think that we can use IVL for to treat the ostium. But after we pass the angle, I think we need IVL because the lesion is still heavily calcified. But we don't have bigger burr. At that time, we don't have IVL and or OPN. So probably we need
absolutely. There is a role for every device. I don't think
there's a complementary.
And Bashir, anything in the comments?
Doctor's question, please.
Yes,
Dr. Faraidy. The second case, when you did the rotablator, your wire is not very distal; it's just very minimal. Is that was
not advanced? this is a tricky situation, and this is not a safe procedure, because actually we need to advance further deeper in, but I cannot advance considering the almost Z-shaped angle, even to the diagonal. So I advance the burr very, very carefully, very slowly, with a slow packing motion, just to break the calcium, and then after that, fortunately, I can advance my blood.
Sure. Dr. Tegu, I have a comment on your left main case. This was a phenomenal case. I must say that I would not have actually went ahead and do this one. But the interesting thing was that as he was mentioning about the wire positioning, you actually positioned the wire in the diagonal, I think, and that was a straighter path for the, or maybe it was a Remus, I don't know, but it went straight in and it was a very short. So I will call it as a halfway wire and a halfway rota. That is how it works.
Yeah.
But very, very nice case. Congratulations.
Very nice. It's definitely not for the beginners in rotational or atherectomy arena. Shall we move on to the next presentation?
Okay, so I'll go ahead, I think, with my presentation. And let me just come up with the slides.
Thank you.
Yeah, thank you, Tegu. That was great. And I think, yeah, we will. Can you see my slides?
Not yet.
Not yet? Oops, you can't see my slides? Or did I, hello?
No, we cannot.
You cannot. You cannot see my slides. This is not good.
So you have to do a screen share. I think you have the
presentation. I got it. Yeah. I'll do screen share. Let me just see.
Take your time. This is more terrible than halfway rotation.
Rotational.
Meanwhile, one more question that I want to entertain from Prabhakar Shetty from Bangalore is, has anyone done IVL in carotids? Michael, are you still online?
Michael is still online, yeah.
I haven't heard of any cases being done in the carotids, but I don't know if the carotid are usually very calcified. But theoretically, you can do it, just provided you use the peripheral sort of IVL balloon.
Right.
But I have not done it before.
Yeah, me neither.
Share.
It's off-label, by the way, right?
Yes.
Yes.
I'm sharing screen.
Don't try it at home.
Oh, you have not shared your screen as yet.
Yeah, now I've shared my screen, have I?
Yeah, we are seeing it now.
There you go.
It has come.
Yeah, good. Okay. So now you see the sharing screen. Okay.
Right.
So what you're going to talk about is, I think, a spectrum of cases, just pointing out many of the things which have been discussed and truly representative of some of the aspects which have been questioned also. So let's just take you to, in 2011, we've actually explained a number of times that do not implant a stent until the lesion is completely dilated in a calcified lesion. I think that perhaps should be the number one message that I'd like to give to the audience. And we've done that repeatedly, and yet even till date, we ourselves occasionally, by mistake, believe that a lesion is pliable and will dilate well and implant stents, finding that we've got an under-expanded stent, or a situation where regularly is referred to as underdilated stents, having been put in a heavily calcified lesion without adequate predilatation. Now, earlier on, when it was 2011, our only treatment for these lesions used to be stent ablations. So like this patient who had an underexpanded stent in a heavily calcified vessel, restenosis in 6 months' time. This is a patient with previous bypass surgery, comes, and then one tries non-compliant balloons up to 24 atmospheres, burst a couple of balloons, still the lesion doesn't open. And at that stage, the only thing we did have was move on to rotational atherectomy, do a stent ablation with a 1.25 burr. In this case, even then it would not open at 26 atmosphere, and then ablate with a 1.5 millimeter burr. and then finally the lesion gives way. Well, like it or not, this continues to happen even in the present time, that you keep seeing these lesions. And therefore, let's take you through what is so clearly we need to understand that even these happened. And we're talking about February of 2018, where there's a high-grade stenosis, looks innocuous, but I'm sure has a napkin ring calcification because the operator sees a balloon not being dilated. And despite this, a stent gets implanted into this vessel, firstly moves distally, and halfway is a proximal part of the stent is into the lesion or partially into the lesion. But then having realized that it's been missed, another stent goes in, and this misses the lesion also and goes proximally. And then we still have a lesion in between. So a third stent goes in, now covering the underdilated lesion. And that's, the operator still tries to dilate that lesion while having implanted a stent into it. And then this is the residual stenosis as anyway, as expected. The patient also has a circumflex lesion, which is not attempted because this residual stenosis with 3 stents is not a great big deal. You can also see the vessel is small. It looks small. It's certainly not been treated well, but of course, this is the circumflex stenosis. Now it comes back in December 2018. This is where we have the advantages now. So for all underdilated lesions, we have 2 options now. So this is the IVUS catheter, which doesn't go in. After a bit of taking away the restenotic fibrous tissue part of it, one is able to then image this, and it's clearly a circumferential calcification with marked under dilatation and understenting of the vessel with the luminal areas inadequate compared to the vessel size of 4, 3.5, and 3.75. So, of course, we talked about the ultra high pressure balloon, but here's the advantages we now have. We could either use intravascular lithotripsy in such situations or the ultra high pressure balloons, which also gives us the advantage not just to go to the high pressures. And here's a 3.5 millimeter vessel. Somebody asked, would you take a 3.5? No, I would not. I'd take a 3, go up to 45 atmospheres, and the lesion gives way, and that's what I would do when I'm using an ultra high pressure balloon. So that's the second point I wanted to make. And then, by the way, even an ultra high pressure balloon does grow. It grows less than the non-compliant balloons. So at 45 atmospheres, a 3 millimeter balloon would get close to a 3.4. The only issue is that a 3.4 would be achieved by a 3 millimeter non-compliant balloon at 24 to 25 atmospheres. And then, of course, this is 4 millimeter test implanted to high pressures. Now look at the vessel, it's huge. And that is, now you get large areas. And that is why we believe that many calcified vessels are underdilated if they're not imaged appropriately. So it's not just that. And again, I'm not passing it on to the experts. It's for many people in the audience that we continue to. But the other message in this patient is that this circumflex lesion is bound to be similarly bad because a patient has one heavily calcified lesion, he has multiple heavily calcified lesions. And that's another message that one needs to understand. And therefore, it gets very important to image that. And as we image the circumflex lesion, you can see, though it's calcified, again, it's a napkin ring calcification. So in this, what would be my options? This is the option prior to IVL. This is, remember, 2018, we introduced IVL. I introduced IVL into India in January of 2020. So here it is, napkin ring, okay, a 1.5 burr. Would that be adequate? Look at that again with a non-compliant balloon. We actually have a waist. So I decide to take in, of course, a 1.75 burr. We have the option of 2 millimeter burr, OP and ultra high pressure balloon, and IVL is what I would do at the moment, an IVL. At this case, it was 1.75, followed by an OPN, the same 3 millimeter OPN. This is a 3.5 millimeter vessel. Look at the OPN bursting at 40 atmospheres. But the advantage of OPN bursting is the fact that it bursts in most instances like this rather than a jet. It actually traverses, it tears rather than gives a jet. And therefore, it does cause a dissection, but it doesn't cause a perforation at 40 atmospheres. And then, of course, it's a 3.5 millimeter stent implanted again at moderate pressures, and we had a good result. So again, a combination of technologies is what gives you adequate MSAs in a concentric, heavily calcified vessel which is resistant. So combination technologies, importance of vessel sizing to avoid complications, and perhaps the deep and thick calcification are best treated by IVL. Coming to rotational atherectomy, I mean, this is an 84-year-old, unstable angina, marked ST segment changes on IABP, angiogram done at another center, referred to us. He's got chronic kidney disease and obstructive aortic disease. Just look at, so of course, his ejection fraction 30%, ACS, but he's got his last remaining vessel, and I think I want you to see that. That's heavily calcified, tortuous vessel. RC is occluded, and these are tortuosities on two planes, as you can actually see. This was obviously with the hemodynamic support, but the 1.5 per after 7 minutes of burring time doesn't move from this place. I managed to get the rotor wire down, but the burr will not grow. Possibilities, this is why I want to transfer these possibilities. This is not even a halfway rotational atherectomy. This is nowhere rotational atherectomy. It is not even going to go through those. When we have a 1.25, this is not where I would upgrade to a 1.5. I don't believe a 1.5 would burr. By the way, the reason 1.5 can work in many instances of a 1.25 not working is because the burring area is larger. And therefore, if you actually create a space, you'd actually be able to get a larger burring area. But penetration force is going to be higher with this oblong P-shaped burr, except that the greater issue of entrapment. And by the way, in this case, the burr did get entrapped, but I was able to yank it back. Now, this is after 7 millimeters of burring time. There is no balloon which would cross it, none whatsoever. Number of 0.8 and 1 millimeter balloons, and none of them would cross it. None of them would even peck inside to actually cross it. So I'm faced with a situation which is practically unfathomable even after 1.5 to 2 hours. And of course, then the better way to do it is take these small balloons and keep on bursting them inside the lesion. Implosions, as we call them. And CTO operators do this fairly regularly for heavily calcified vessels. And I think I burst 6 or 7 balloons in this lesion to get me enough space for the rotablator burr to advance. So upsize, downsize, we just discussed the upsize issue. By the way, there are 2 things you can actually do. If a 1.5 millimeter burr doesn't cross, then you actually move to a 1.25 millimeter burr. If that doesn't cross, move from a floppy rotor floppy to a rotor support, and if that doesn't cross, move up on the rotor support to a 1.5 burr. That's the algorithm for uncrossable rotablator, rotational atherectomy uncrossable lesions. So implosion is one of the things laser, front-end laser could have been, which I don't have, but it is again a 10-minute of burring time on the 1.25, and finally that 1.25 millimeter crossed. In our present time, after this crossing, I would definitely go on to a 1.75, but to follow up with an IVL in such heavy calcification. But that's the burr crossing. Then it was followed by a 1.75, and you can see that the 1.75, and it's actually, remember, it's in 2 planes that is seen. And then, sorry, gosh, let me just go back. And of course, we had that finally stented, and that was the result. I lost that branch. Do you see that? That created a lot of problems, and I had to get that branch back, the first big branch, as you can actually see. I was able to get that branch back, but this patient actually really, for the next 2 days, was terrible. It took him enough time because I had, by the way, stunned his myocardium. Ejection fraction dropped from 30 to 20. Prolonged ischemic time is what happens when we deal this. Briefly, again, halfway burring comes up here. Osteoproximal LAD and a circumflex which is heavily calcified. I'm not going to dwell on the circumflex because that's just rotational atherectomy followed by a stent, a 1.25 burr followed by a stent. But the LAD is revealing. It's actually Osteoproximal spreads right from the ostia. And this is again, sorry, did I lose the track? I should have got this. Yeah. So there are this, I think it's been missed out. Forget this one because the clear one, the messages I had got missed out in this. Let me just go to my last one. Right here it is. Sorry, the message is right here. So the 1.25 burr cannot cross it. Again, it's because of angulation in that, and this is a 2-minute burring time. A balloon dilatation helps for that burr to cross, but then again, it doesn't cross for another 3 minutes at the distal point. Angulated segment at that particular point, it doesn't cross it halfway. So what do? We take a non-compliant balloon out there, and that bursts at 26 atmospheres. So this again becomes a case for an IVL, a shockwave balloon with a guide liner being thrust across that tightest point. It only goes halfway across the tightest point, but then deliver shockwave. That's the first part, is it totally delivers halfway, then you create more space and then deliver 80 pulses all the way up to the ostia. And then OCT guided, you actually do good osteal stenting, covering, of course, first the distal and then the proximal. And then you're actually finished with this, again at high pressure dilatations, but you have an OCT guidance, gives you good positioning at the ostia with really 2 struts only covering the circumflex with a good optimized result. But finally, the one of the worst cases I'd like you to understand and how to combine things together is this, I think is this case, yeah. So if you just excuse me for this, and this perhaps represents to me the real combination why we call it. So it's shepherd's crook. This has been intervened once. Unfortunately, the previous operator could only get somehow a stent in the mid segment, but could not dilate it adequately. It was underdilated and this patient re-stenosed rapidly. But there was a whole segment of his vessel which hadn't been. And I, by the way, when I saw this, I didn't have the previous angiogram. I couldn't know where the stenosis was. This vessel was so calcified, so heavily calcified, that I didn't even know where the stent was implanted. But I was told that there were 2 stents implanted. I could figure out. Anyway, I guess one of them would have been in the mid segment where it had re-stenosed because it had only been partially dilated. It was upward going, and it was in a 90-year-old. So we had multiple support. We had a long sheath, AL1 guide, Grand Slam wire, guide liner, and a 2mm balloon would not cross that distal point, as you can actually see. So it's a guide liner and a 2mm balloon would not cross. Even a 1mm balloon would not cross. A microcatheter would not cross the distal point. This is as heavy as they get. So of course, decided, of course, the first step is a burr. So that gets you space. With a 1.5 burr, the lesion's dilated with a 3mm non-compliant balloon at high pressures, and lesion dilated with 3.5. Now the guideline is still in place because there's a stent which keeps stopping everything from going in, which is underdilated right at the top, and that's how I guessed it. This, of course, was followed by an OCT which told me that there was stent in the mid segment. It was totally underexpanded. This vessel was close to 4.5 millimeters. I actually then went ahead and post-dilated this with OPN balloons, 3 millimeters in the distal and 3.5 all the way up to where the stent was, and a 4mm in the stent. Oh, sorry, before that, I do an IVL, again put through the guide liner. Having seen that much of calcification, and by the way, there was circumferential calcification well seen at the distal point, a 3.5mm IVL is taken, and 80 pulses delivered all along, with at least 30 pulses were delivered at the mid segment of this lesion. Used 1 IVL, I could have used 2. This was followed by an OPN, followed by implantation of stents from the distal all along into the mid segment, which had been dilated by an OPN at 4 millimeters. After this, took the OPN. Further, the earlier dilatations had been done at 20-25 atmospheres. Now in the stent, It goes up to 35 atmospheres for the distal part, a 4 millimeter OPN for the mid part, followed by an OCT, which demonstrated or already demonstrated a 4.5 was needed for the mid. So a 4.5 OPN at 40 atmospheres for the mid segment part. To get that lesion, to get that result on this vessel. This is OCT. This part was dilated with a 4.5 at 35 atmospheres. This is the best I could get, but I think I got an adequate result on a very large vessel, which had already had stents, which was underdilated with circumferential calcification. And that's what brings me to the important point that I got adequate lumens all around on OCT, which brings me to the important point that it is clearly, this is the final result. I was quite happy with the final result because it was OCT assessed and because I'd done. There was a calcium nodule, by the way, which actually remains. So calcium nodules are difficult to treat. Imaging is essential for optimization. And for these worst sort of cases, we now, in the present era, do need combination modalities. It could be a combination of rotational atherectomy, followed by IVL, and followed by OP and ultra-high pressure balloons to give adequate lumens in these extremely calcified vessels that we keep seeing now in our daily practices. Thank you very much.
Thanks, Ashok. Yeah, Ramesh, go ahead.
Yeah, no, excellent presentation. I think, Ashok, is really, you have shown how to approach each different type of lesions, where a regular balloon to OPN to IVL, and also you have used rotational atherectomy and really terrific complex patients. Jack, any comments?
Is there any comments from either Bashir or
Yes, yes, I have some comment.
Yeah, please go ahead,
Dr. Rahman.
The two cases. One is Tagos. Another case is Dr. Ashok. That is a fantastic case. Then my imagination is that in the Tagos case is that he rotablated and putting the bar at the darker portion of the wire. The darker portion is the softer. Is there any chance to that is damaged of the wire or entrapment of the wire? And the Ashok said, you have dilated the LED. That's very tortuous and aneurysm. So which is the lesion is absolute contraindication of rotablate, and how far you will try for that? So this is a fantastic case, but you tackle it very nicely. Yeah. Both of the presented very elegant. Every present is very elegant.
So I think, thank you. Tegu, I think firstly, let me just take the question around, see, extreme angulations have to be done very gently. And I think Tegu pointed that out halfway. The way we do angulations, but then we get left vein circumflex angulations, which are usually right angle. The advantage of that is that it comes from a large vessel into a smaller vessel and you ease it. You get LED going into the diagonal. You just have to remember the fact that it's going to cut across and there's a guide wire bias happening all the time. You have to understand where the biases are happening and where it will actually cut or where it may perforate and it may not even go through. You got to ease it across bends and curves. That's very important. The moment you feel that it's going to go straighter rather than take the curve, and it won't take the curve, by the way, if you actually got the disease process very tight prior to the lesion, because that's when it'll come out at an angle. To take a turn, there has to be enough space in the vessel for it to actually bend. Remember what we said just now, the oblique angle of a burr is the same for all burrs, but if you actually have a larger space, then a 1.5 can take the same curve as a 1.25, and a 1.5 blade further more. So you just have to ease it down the corners. But any place where you actually feel, if it's greater, I would say if it's, I mean, we go across even 75 degrees, we go around 90 degrees, but we have to take small burrs, ease it out, ease it across, and make sure that we don't have, we will on occasions go through a media, but we shouldn't go through the adventitia. That's the main thing. Stop when you feel it's unsafe, and go with a balloon. With a balloon. So you don't have to take a burr through and through the lesion. Do halfways, because the rest can be tackled with a balloon.
Can I say something, Ashok? I think outstanding cases, no doubt. The traditional teaching in the past had been that if there's a dissection, then you should avoid rotational atherectomy. And I know now we are doing it even up like halfway atherectomy and balloon burst, and like up to what extent dissection there is which is going to inhibit you not proceeding with rotational atherectomy.
Brief answer. It doesn't bother us. Brief answer is that.
Okay, good.
Getting the lesion open is more important.
Sure.
So, can I ask a question?
Yeah, can I make a comment here? So these cases which we saw are really phenomenal cases and very, very difficult. But I must say that this technique which Dr. Seth showed of the, creating explosions inside, that was quite intriguing and very interesting. And certainly it works. And we have seen this that, you do some 1 or 1.25 balloon dilatations and, sometimes these balloons burst. This used to happen by chance, but now we are doing it because it used to, started working that way, that these balloons burst and then they create a passage for the, the rota to go in. And the other, thing about using a bigger burr, I think is also a very nice idea. And, it works quite well. That you can use a bigger, but it is safer. It takes some time, so you just can't push it in straight away. It has to just spend some time, have patience, and then gradually it will make a passage inside. So thank you very much for this wonderful cases. I learned a lot.
Thank you, Praveen. Thank you for your comments.
Yeah, Dr. Khalid, maybe we come back to your question last after Hui Chim's last case, then we can group the questions later.
Thank you, Dr. Ashok. It's very interesting cases that you presented for, especially as a big dilemma for us, uncrossable lesion. When you cross a wire and you cannot cross with even smaller balloons, very challenging, and you presented elegantly. Other technique, I don't know, have you experience with that? One of my colleagues, I haven't tried it. He used turnpike spiral to screw it and go with that. I don't know, have you have any experience with that?
Yeah, Taurus is not with turnpike spiral, but Taurus. And these sort of angulated heavy calcification, it doesn't, I think I tried it in this, it just would not even budge. Yes, that was also tried in this. I didn't show it. It was a 5-hour long case, and that's why I showed what was really relevant, but that wouldn't even get anywhere. It just wouldn't even budge half a millimeter into it.
Ashok, can I get you to stop share so that...
oh, yes. You're so right. Thank you.
Yeah, no problem.
You.
Yeah, thanks, all great comments and questions. Maybe in the interest of time, we move on to Hui Chim's presentation.
Oh, Hui Chim hasn't presented?
Yeah, because we move on to Daegu first.
Oh, I see. Okay. Hui Chim, sorry. I thought I was the last presenter. So I took more time. Okay, go ahead. But this is all, it's all learning.
Right, team, we can't hear you. We can see your slides.
Because I'd got disconnected for 10 minutes, I didn't know that it hadn't been presented. So we receive sincere apologies to Hui Chim.
No problem. So thanks, Jack. I apologize. I may be standing between your dinner and your bedtime, perhaps. So, but I think the talk that I'm going to be covering will actually complete the pictures for tonight. Having gone through ultra high pressure balloon, rotational atherectomy, intravascular lithotripsy, I just want to share with you the best and worst of orbital atherectomy that I come to know about. I think we are all very familiar with rotational atherectomy. This is a unidirectional front cutting device. Okay, so you can only create a lumen size as big as the burr, and during the burring process, there's actually no blood and micro debris that can flow through the burr. But when you look at orbital atherectomy, it is quite different. It is a bidirectional cutting device, so you can ablate as you go forward, and you can ablate as you come back as well. And it's also because of this orbital rotation that it exerts a centrifugal force that is directed against the vessel wall. So there's also a pulsatile force that is exerted on the vessel wall besides this sandblasting effect of orbital atherectomy. And this is a one-size-fits-all. So this 1.25 burr can be used to treat vessels from 2.5 to 4 millimeter, and it allows for continuous flow of blood and saline during orbit. So there are three factors that determine how much of a size that you can get from a single orbital Diamondback 360. The number of passes that you do will determine the ultimate size. The speed at which you advance the burr or back forward or backward, 1 millimeter gives you much bigger ablation compared to a 10 millimeter per second sort of ablation speed. And the higher the speed of a rotation, 120,000 versus 80,000, gives you a much bigger burr. So a combination of these three events determines final luminal size of the vessel. And this is where I think orbital atherectomy is best. This is a patient with a very large vessel, as you can see on the still picture on the right side. This is a 4 millimeter vessel. And if you were to do an intravascular ultrasound of this patient with this concentric calcium, and if I magnified it, this is a concentric calcium with a inner luminal diameter of at least 225 or maybe 2.5. There's no way any burr can actually achieve any sort of ablation in this sort of lesion. And this is the situations where I feel orbital atherectomy is at its best. So you can do a back and forth sort of a slow ablation, and you can increase the speed from 80,000 to 120,000 slowly, and then eventually you can finish up with the balloon size of your choice and giving a very good results in a very large vessel. But the worst of orbital atherectomy will be these particular complications that I want to share with you. This is a 63-year-old diabetic and end-stage renal failure on hemodialysis. So you can imagine this is a calcified arteries that we're dealing with. This patient had a previous bypass surgery 10 years ago with a lima that is being used. And then he had a subsequent PCI to his right coronary artery about just 4 years ago. And then he was admitted to another hospital for recurrent non-STEMI. So I want to show you the PCI that was done in 2015. So not sure whether you can see the stent. There was a stent put in the distal RCA. There was a stent that it put in the mid RCA. And so this is a stretch of a stent that was implanted from here to here. So this was the position of the stents that were put in 2015. Now, 4 years later, he came in with a chest pain. And this was the disease that was distal to the stent, obviously. Right? So you can see that the distal RCA was severely diseased. Right here. So the operator decided to use an orbital, which is fine. But as he advanced and then pulled back the orbital atherectomy, the device got stuck. Now you would think that this is like a usual sort of burr, rotational atherectomy burr that got stuck, but it's actually not quite the same mechanism. But anyhow, this burr is stuck right now. And so now begins the entire 4 hours procedure of trying to retrieve this burr that is stuck. So usual technique, put in a second wire, try to balloon, create some passage, dislodge this particular burr. Not successful. Took a mother and child balloon with a snare inside and tried to pull the burr. Did you see what happened towards the end of this procedure? I want you to take a closer look at this burr as it comes back halfway through. What is happening here is that the burr got intertwined with the stent, and part of the stent was stripped off from the distal end of it, or leaving the proximal part of the stent that is still endothelialized. So the stent got stuck here. A patient obviously in terrible situations. So I think that was the end of the procedure. There was no way the stent, the burr could be retrieved. And so the operator, apparently a surgeon, simply just cut the shaft and leave this entire device in the patient's right coronary artery at the end of it all. So now we have a device that is left in situ. He comes to my hospital 6 weeks later with unstable angina and STEMI again. And we discussed with the heart team a long time. If we go to go in and do a surgical retrieval, it will be going through the lima, which is terribly not particularly appealing to the surgeon. If we do a percutaneous, I don't think we will be anywhere near as success as what was already attempted before. So we decided to have actually a hybrid approach, where the surgeons will go from the right thoracotomy approach, access the RCA, somehow dislodge the the head of the RCA, the burr, from the stent that is intertwined, and then the percutaneous and the interventionist will try to stand it out. Unfortunately, the patients refused, so we couldn't do anything, and we just treat him medically. And 7 months later, he came in again with left lung lower limb non-healing gangrenous wound. We took him to a lab to do a PTA, but that was unsuccessful too. He went for a lower limb amputation, and he had a cardiac arrest 2 days later and passed on. So this is a terrible situation, telling me that when you have an in-stent stenosis, I think orbital arthrectomy is a real contraindication here, because you just don't know how much of endothelializations has taken place. So I think the indications for orbital arthrectomy, to me, having seen some of the cases that is being presented, when you have a discrete large vessel stenosis, it's perfect. When you have a thick calcium cap that you want to thin out somehow, modify somehow, orbital arthrectomy is great. Eccentric lesions where you have no good options, orbital arthrectomy becomes an alternative. It's best for superficial calcification and not for deep. Certainly, contraindications will be very tight lesion you can't go through. You need a rotor in the case. If it's too small vessel, less than 2.5, don't even try orbital. Angulated lesion is not recommended, and in-stent stenosis, in my opinion. So with that, thank you very much.
That is.
Thanks, Wichim. Fantastic summary.
Fantastic.
Yeah, very fantastic. Can I maybe ask whether there's any comments or questions from everyone in the panel?
Yes, may I ask questions?
I have also.
Yeah.
May I ask a question?
Yeah, go ahead, please.
Yes, this is a great case. We learn a lot from you. I just want to give comment regarding if you have long lesions and we have to pass that lesions with either rota. So from time to time, we can still use rota, but probably it's not very safe for orbital arthrectomy. In this kind of situation, we can use kite liner. We use a kite liner and pass that standard lesions with the kite liner, and then we use rota to fix distal lesion. If you have a lesion in the distally, we want to fix that.
Fair enough, yes. Actually, this lesion looks very tight for orbital, so I may not even consider it, because orbital, your nose cone needs to go into the lesions first before you can start to ablate laterally. It is unlike a rollerblader where it's cutting at the burr tip. So this being such a tight lesions may not be a good lesion to treat with orbital.
I think that was very good, Wichim. The perspective on when not to use it was tremendous, and the complications. But yeah, these are frightening complications, and I still can't believe that it was left in situ and patient sent home. I hope it wasn't coming out of his groin.
So I think it was cut off, and then the shaft got recoiled into the body. The
correct. So I'm sure something. It must have been in the aorta somewhere, because it would have recoiled out. But wouldn't have been nice to see it outside coming out from the.
I have a question for Professor Tan. Very excellent presentation. Really very nice complication you presented. Not to use as Professor Ashok mentioned. My question to you now, we know that the indication for rotational or for the orbital is for large vessel, where rotational cannot use. Now with having the IVL, the shockwave IVL, do you think is any rules for going to be expanded in the orbital atherectomy, or what do you think the future for orbital atherectomy?
Well, actually, even with the availability of shockwave, I feel that if the calcium is really very thick, the shockwave may not perform as well as the orbital arthrectomy. I think if you can shave off, you can modify, you can thin out the calcium cap, it makes it much easier for you to actually expand it, the stent. The shockwave problem is that while it can cause cracking of the calcium cap, which is thick, sometimes you have this rupture that's happening that we are seeing and we talk about. So it occurs in about 10%. We have about 4 or 5 cases of balloon rupture simply because it's just too hard a lesion. And this current iteration of a shockwave balloon is a thin balloon wall. So until the second version come on with a thicker balloon wall, we're going to be seeing cases of balloon ruptures, which may not give you the full ablations or full shockwave or lithotripsy that you expect from this balloon. So So I think the orbital still has its role. So it all depends on your personal experience and judgment. It's all about skill, judgment, and experience, isn't it, in this field of interventional cardiology?
Yeah, so about orbital atherectomy, I may add some points. That one of the important things is that to cross the wire, it is much easier than the rota wire, because you can use a normal wire, and the other thing is that you can use it in big vessels. Now the thing is that if you compare it with the IVL will not be able to work in many fibrocalcific lesions where there is eccentric calcification, where there is a nodule. So in those kind of cases, orbital will still be a reasonably good idea to use. And we were actually part of Dr. Seth and myself. We did the Orbit 1 trial, which was the first in man for orbital atherectomy. And fortunately, we do not have that device now in India.
Yes, Praveen, yes. We were the first advanced study of orbital atherectomy.
So it is
10, 12 years ago.
Yeah, so many years ago. I think
40 years ago.
So we still actually use the proprietary Viper guide wire provided. We don't use coronary wire, but you're right, this wire performs like a coronary wire. It's much easier to manipulate than a rotor wire. But we will still use the Viper wire suggested. And we will also use a Viper glide, just like a rotor glide that is recommended for a rotational atherectomy to reduce the barotrauma and the thermal injury that comes with it as well.
Do you know that questions are still pouring in? I have a list but we have really, I mean, it's been, can you believe that we are been here for close to 2 hours? Yeah, no, it's more than that. 2.5
so Professor
hours.
Tang,
We're going to come to 2 hours, 20 minutes. So I think
sorry, no, that's okay. It's this is Gaku. So I have one question. So since IVL is not approved in Japan, so we haven't used this IVL or OPN. So what's the combination? Is it okay to combine like OAS plus IVL or rotor atherectomy plus IVL? Like after ablation, can you use IVL or OPN?
Of course, you can use. Yes.
Okay. If it's yes, which combination is ideal? I'm curious.
Actually, I go with what you said. I think it's lesion dependent. This is where your judgment comes in. There is no specific one size fits all. It's just like a bifurcation stenting, the technique you choose depending on what sort of lesion that you're dealing with. My take here is that because of a cost consideration, you want to choose a particular modality that will deal with it one shot and not have a combination, because every time you put out a new device, it's a new cost. So shockwave costs 3,000 Singapore dollars, and and so if you take out one, you rupture, you take out another one. I mean, there's a lot of cost involved here. So I would like to choose one that will give me the final lesion preparations that I can get, and then to finish out with a stent.
And also, how helpful is the OCT or IVAS in that kind of decision? Like,
I think image guidance will be very helpful here. Tells me the lesion morphology, the length of calcium, the thickness, and so forth. So I think it's very helpful.
Thank you very much.
Thank you. Do you use a lot of orbital, Gaku?
Yes, we are now using a lot also, and like you said, like a large vessel without angle. Sometimes it's angle, but not very tight. But it's a good indication for OAS, I think. But rotor atherectomy is still we need that in case of severe stenosis, long lesion, like angulated lesion.
I just want to add a comment on angulated lesions here, particularly osteocircumflex. Now, when you have a very angulated lesion, orbital is no good in terms of advancing it in an antegrade fashion. The best way to use orbital is to advance it beyond the lesion and then do a retrograde pullback to do the ablation. Because if you go antegradely, you find that the burr will be actually going against the left main, and there have been a couple of cases of left main pseudoaneurysms reported with this antegrade advancement of orbital atherectomy. So
I completely agree that we always pull
Mr. Tan?
atherectomy. Yes.
Dr. Tan, I suggest if you can please stop the screen share from your side.
Okay. So yeah, thank you, Wei-Ching. I think in view of time, we'll just take a couple of questions actually from VT Shah from Mumbai. His questions are about does orbital help in calcified nodules or angulated lesions? I think you have already answered that. And the technique and RPM for stent ablation. So with the OAS, what do you think, Wei-Ching? So, in my opinion, that stent ablation, you have to be very careful whether it is orbital or rotational. You might have to be at a higher RPM in not lower. And I think if you're at a lower RPM, where I think in Japan you still have 40,000, where in US we don't have that. We have 80,000 and 120,000 RPM for orbital. So I would actually try to say that you should go slightly higher RPM if you are doing stent ablation with the orbital. And please beware that you may get stuck as it happened in the patient. And that patient ideally should have received emergency bypass. Even if the device was left, I think they should have done a distal bypass to that vessel. What do you think, Wei-Ching?
Well, the trouble is that he already had a bypass before. And so the surgeons are terribly reluctant to go in the second time to retrieve a device from the RCA. So that was the dilemma we had.
Yeah. So I think a great session to wrap up.
To leave, so bye-bye to all of you. It was a great session.
Yes.
Yeah,
so I think
a fantastic way of approaching calcified lesions, the different lesions, that presentations from all three speakers, Wei-Ching, Dr. Ashok, Seth, and Tegu's, half rotational atherectomy. I have learned myself a new technique, and I will start applying that. We also have to be careful, as I think Dr. Al-Faraidy mentioned, that if you're really, or I think Gaku, very close to the distal wire, maybe rotational wire fractures can happen, especially if you're an angulated lesion. So be careful not to be very deep with the rotational device, atherectomy device. So, and then I asked my co-moderator, Dr. Jack Tan, to make a few comments, and then we can close the session.
So I think it's late in the night. I think Ashok is still having connectivity issues, worse than Bashir, but I think it was a wonderful session. I would just like to comment that I want to thank my speakers, the panelists, and the participants for their time tonight. Great questions coming in from the web, and we hope we address most of the questions. A quick summary, I think there was a lot of concern, and I'm very glad we had this session about the use of this adjunct therapy, whether it's a scoring balloon or the high pressure balloon. The main concern for the high pressure balloon, if I may summarize, the concern about perforation, which if you use correctly, I think that is quite rare and is very safe. I'm happy that we have this adjunct of an OPN balloon. In regards to the algorithm, that was the other major questions keep being asked. I think the algorithm really depends on your experience, your expertise, availability. I like Wei-Ching's summary slide where it weighs the pros and cons, and try not to use 110 adjuncts. I think it's good that there is options for you. I think Lithotripsy, Rotatripsy, OAS Tripsy, all these other combinations are now possible. And with more experience, we're doing more and more challenging subtypes. But just caution, like rightly put by Wei-Ching, complication can happen. And in calcified lesion, if it does happen, it's terrible. So we also have to be wary about the complications in these cases. So with that, on behalf of Professor Ashok and my co-moderator and all the speakers, we thank you for your evening with us tonight, and keep safe again during this COVID period. Thank you very much, and goodbye.
Thank you.
Thank you.
Bye.
Thank you.
Thank you a lot.
Bye.
Bye. Good night.
Bye.
Thank you, Michael.
Good night, Dr. Raman.
Goodbye.
Thank you, Ramesh.
Thank you. Bye-bye.
Thank you, Ramesh. Thank you, Michael Lee. And
Thank
Cassese.
you.
Thank you, Cassese.
Thank you, everyone.
Thank you.
Thank you, Michael.
Thank you, Tagos.
Thank you
Thank you
very
very
much.
much. Thank you. Thank you.